Hello and welcome to the University of Washington, Washington Area Cardiometabolic Project Echo Session 10. I'm Nicole Earhart, one of the adult endocrinologists at the University of Washington. We're so excited for this Echo program to continue. For every session, we do ask you to help us empower our patients living with cardiometabolic disease, and also note this is a safe space, as that there is zero tolerance for making people uncomfortable, as really that's the heart of the Echo model to build a learning community together. So now I'm excited to introduce our speaker for today. So our agenda, we're going to be doing a talk on improving cardiorenal event rates, and we're going to discuss cardiometabolic benefits of renal diabetes and obesity medications. And this will be by Dr. Christo Argelopoulos, who's an assistant professor of medicine at the University of New Mexico. Please go ahead and introduce yourselves.
Hi, everybody. Thank you for having me today. I think this is the second time I present to your ECHO program. We'll be talking about cardiometabolic and kidney benefits of new therapies.
Thank you. And now I'm going to go ahead and introduce your panelists. Dr. Lorena Wright, could you please introduce yourselves?
Hello, everybody. I'm Lorena Wright. I am an adult endocrinologist at the Diabetes Institute, University of Washington.
And now Allison Everett. She's our great nutritionist with wealth of experience and actually has done some of the guideline writings for ADA and nutrition. Go ahead and introduce yourself.
Well, I will just tag on and just say that I have over 40 years of experience in this field and am currently a diabetes and nutrition education consultant. Thanks.
And then Dr. Laura Montour, please introduce yourself.
Hi, it's good to be back. I'm Laura Montour. I'm a family doctor and obesity specialist and the co-director for the Center for Weight Loss and Metabolic Surgery at UW.
So now without further ado, go ahead and share slides and we'll start our excellent program.
So there was only one disclosure that's not relevant for the topic. It's with a company that makes home dialysis equipment. So the objectives for this therapy will likely not be able to go through all four of them, but we'll try to stick with the first three, is to review strategies for selection of the new therapies, review the data that support the current drug treatment paradigm for the treatment of diabetes and kidney disease, and discuss the risk management of new strategies. And time permitting, we'll talk a little bit about special populations like the elderly and kidney transplant recipients. The reason we're having this talk is because diabetic kidney disease is still pretty much of a problem in the 21st century. So these are the data from the United States Renal Data System, which kind of tracks the evolution of end-stage and chronic kidney disease. And as you can see, we have quite a few of individuals who live with CKD in the United States. It fluctuates at about 10%. And despite some dip in the numbers for patients who live with diabetes, we saw an uptick at the beginning of this decade. Granted, the GLP-1s will probably change those slides, but we're not there yet. Probably one of the reasons we're still talking is because we want to get to a better future in terms of the prevalence of diabetes and chronic kidney disease. Note that the presence of CKD or the prevalence did not go down despite significant advances in how we treat these patients. So over the last 20 years, we've been using glucose-lowering therapies more aggressively. We have been increasing the use of ACE inhibitors or ARBs. People may say that what appears to be a prevalence of use of these agents of about 50% is low, but there was a recent trial, which unfortunately we don't have time to review, by one of my former co-fellows at the University of Pittsburgh, which suggests that the 50 or 60% is probably the ceiling of use of these therapies you can achieve. But continuing on the process improvement, we've been treating, using statins more aggressively. We've managed to lower the A1C, lower the blood pressure, lower the cholesterol, and the problem still remains. So we'll do a short quiz just to reorient us with what the modern clinical phenotype of diabetic kidney disease is. So in this case, you're about to see a 58-year-old patient who's had diabetes for more than 15 years. The control could have been, is not horrible, but could have been better. The A1C was maintained between 7.5 and 8 for the last 8 years. The patient did have stroke 6 years ago, but they have no retinopathy. Their current blood pressure is 135/80 on 100 milligrams of losartan and 1.25 milligrams of indapamide, which is a thiazide diuretic. They have a GFR of 45, and the last urine albumin to creatinine ratio is 18 milligrams per gram of creatinine. That is a very frequent presentation in my clinic, and one of the questions that people ask is what could be the potential cause of chronic kidney disease? So the answers is A, this cannot be due to diabetes because the UACR is low. B, it cannot be to diabetes because the patient has no retinopathy. C, it is likely due to diabetes because the A1C is not less than 6.5. And D, cannot rule out a diabetic or a non-diabetic cause based on the information provided. We can take a few seconds and maybe you can put your votes in the chat. Because this is a very frequent occurrence in our clinics. We'll give everybody a few seconds
And C and D seem to be the most common answers.
Yes, and actually it's D. I frequently see people like that in my clinic, and really on the information provided, you can't really say. It can be either or. And I will say that increasingly the answer is important to know, but is also irrelevant to know because of the use of expanding use of therapies from the diabetic kidney disease spectrum to the non-diabetic kidney disease spectrum. Regardless of what is causing these particular patients' CKD, though, the problem we are trying to solve in our clinics is not just what the A1C is and what the level of the GFR is. We are trying to address a more general problem that of the intersection between kidney disease or among kidney disease, cardiovascular disease, heart failure, and cerebrovascular disease. This again, diagrams from the 2023, the most recent report by the US Renal Data System. Our reports are actually released towards the end of the year. The 2024 is still like pending updates. And it kind of shows that if you take a snapshot of the patients with chronic kidney disease in this data collection, you'll find out that patients with diabetes and CKD are also more likely to have things like. In fact, the problem we should be solving in our clinics is not just the metabolic control or the addressing the level of kidney function, is really preventing the entire spectrum of cardiovascular, heart failure, and kidney complications, what is increasingly being known as CKM, chronic kidney disease metabolic syndrome. In fact, if you take a broader or a global view, we'll find out that out of the nearly 500 million people living with diabetes, the majority of them will not reach the point where they need dialysis. They will die somewhere in the road to dialysis from cardiovascular disease and heart failure. So really the problem we need to be solving in our clinic is the entire package. That's why cardiologists, endocrinologists, and nephrologists are increasingly being pulled together to address those clinical challenges. In the quest to understand who should be treated aggressively, people have turned into multiple biomarkers. There are many, many things that are being explored. In fact, my own research is looking at some exotic biomarkers in the urine and the plasma. But to be honest, right now we do have a very good biomarker in the clinic, which is the level of the urine albumin. In fact, the biomarker itself is the albumin to the creatinine ratio in a random spot of urine. This is an analysis that was done more than 2 decades ago. This was based on the Renal study, the study that sort of introduced losartan into clinical practice. And what they did back then is they looked at the urine albumin in individuals after they've been on the therapy for about 3 months. And they asked the question, does the level of the protein in the urine or failure to reduce the protein in the urine predict who will get into trouble? And the answer is yes. If you are started on an ACE inhibitor or an ARB and you don't reduce the amount of protein in the urine by at least 30%, then you are very likely to experience a high rate of cardiovascular and kidney disease outcomes. In fact, that study also looked at the absolute amount of protein in the urine, and there was there was a dose response relationship, but the way they presented the data was like more of a category or range of values. And based on that study, every single study since the early 2000s has focused on recruiting patients who had persistent albuminuria, a lot of protein in the urine, usually more than 200 milligrams, despite being on an optimal or standard of care therapy, which back then is ACE inhibitors or angiotensin receptor blockers. So the level of the protein in the urine is an important predictor of badness, and it also has been used to recruit patients in trials. Based on that information, we have another case in which we are asked to see a 67-year-old with type 2 diabetes and for history of a myocardial infarction with a stent to the LAD about 10 years ago, an A1C of 6.8, a urine albumin to creatinine ratio of 55 milligrams per gram, and a GFR of 48. The regimen includes metformin, pioglitazone, and sitagliptin. So the question is, what should we do when we see such a patient in the clinic? See him in 4 months, add dapagliflozin, add dulaglutide, or make a plan to flip the entire regimen to metformin, dapa, or dula over the next 6 months. This is a general practice question. Some people may argue that there is still no right or wrong answer. I would argue that there is an answer we should be strongly considering in this case. And I see the votes are coming in and there's a split of the vote, but I would argue that someone like this patient needs to be aggressively treated, and answer A is definitely not aggressive treatment, but answers B and C are not very aggressive treatment. So the correct answer would be to actually try to get them on both GLP-1 and SGLT2 inhibitors over the next few months for cardiovascular and kidney disease protection. This is kind of like based on the current version of the diabetes care document, which was updated in the last few weeks, which kind of say that when we approach someone who lives with diabetes, we will do all the lifestyle modifications were critically important for things, not just the metabolic control, but even like well-being, like picking up an exercise program can be a very effective therapy for some depressive symptoms. But if we are trying to decide how we're going to approach the patient, we need to base it on clinical risk factors and layer our therapies based on their clinical risk. So, for example, someone with cardiovascular disease, like the gentleman in the picture in the vignette previously, would benefit from a GLP-1 receptor agonist. An SGLT2 inhibitor, especially if the GFR was reduced, like the gentleman in the previous picture. So that's why the rationale for intensifying and including both. And then including some other therapies that target blood pressure and the activation of the mineralocorticoid system. And we'll talk briefly about those therapies a little bit later on. So let's talk about the data. How did we come up with this like nice and very regimented approach? So when it comes to the sodium glucose co-transporter 2 inhibitors, they've been being tested in trials starting, nearly 14, 15 years ago. We've had studies like Canvas, EMPA-REG, and DECLARE-TIMI that were cardiovascular safety studies, which looked at people with preserved kidney function and not a lot of protein in the urine. Protein in the urine, you can informally think of it as a damage marker. So then we had studies like Credence, which looked at people with more advanced damage and partially preserved kidney function. This was an overlapping population that was also studied in the DAPA-CKD trial that looked into dapagliflozin. And finally, we had EMPA-Kidney that was published a year and a half ago, which actually looked at people with even semi-normal, to put it this way, measures of kidney damage in the urine, but they decrease kidney function. And these studies, which were kind of boring, actually, the drugs worked. So if you look at the Kaplan-Meier curves, those agents reduce the risk of kidney disease by 30-40%. Doesn't matter which one you use. So they also, when people looked at the level of the kidney function before reaching dialysis, which was what the previous graph showed, they noticed that the rate of loss of GFR, how fast your GFR declines year over year, was substantially reduced by those agents. Interestingly enough, a substantial number of patients on the EMPA-Kidney study, which was the only one that kind of allowed the inclusion of people who could not tolerate the ACE inhibitor, they had about 15% of patients of those. They actually showed that it doesn't matter if you're an ACE inhibitor or not. The drugs work the same, although the benefit was probably higher if for whatever reason you could tolerate an ACE inhibitor or an ARB because you got the benefit from those. However, for the 35 to 40% of patients who for whatever reason cannot be maintained on an ACE inhibitor or an ARB, SGLT2 therapies work very, very well. That does not give us a license now to use the ACE or ARBs, but it just gives us another option in people who could not tolerate them before. In addition to protecting the kidneys, the SGLT2s will also reduce cardiovascular deaths, heart failure, and mortality. The numbers were anywhere from 23 to 15%, and they did so respective of the presence or absence of diabetes, which kind of gets us to the first vignette we discussed, that increasingly those therapies started their life as risk reduction therapy for individuals living with diabetes, and now we are finding out that they are benefiting even people without diabetes. So it's important to realize when you see someone who doesn't have diabetes on an SGLT2, it's very likely that it's based on data like this. Now, SGLT2 agents had received some bad reputation like 10 years ago. This is from a paper that co-authored a few years ago talking about de-risking of some of these therapies. So the things that you'll most likely encounter in the clinical practice is yeast infections. Really, this goes up by 3 or 4 times. We advise patients about hygiene, wipe themselves after they use the bathroom. The scary side effects such as diabetic ketoacidosis require careful attention to how you manage insulin around those agents. So sometimes we see the mistake that insulin is preemptively cut by a huge amount, and then that makes individuals more likely to go into DKA. So in actuality, the SGLT2s are not very powerful anti-glycemic drugs, especially if your GFR is below 45. So if you are going to decrease the insulin while someone is on an SGLT2, do not go over 20% as an initial step and then monitor. The risk of amputations, which was really the bad publication that some of these agents received, is there is a small risk. It's most likely to be seen in individuals who have very active peripheral vascular disease, meaning resting limb ischemia or open arterial ulcers. The most recent studies screened out for those with very active PVD, not asymptomatic, just active like resting limb ischemia. And if you exclude individuals until they've been revascularized, it seems that we don't see the problem as much as frequently. But it's important to know, especially if you have someone who you start on one of those agents and their ulcers sort of like, or their symptoms kind of increased, you may want to be cognizant about stopping those agents. What about the GLP-1s? Those have been also looked into studies similar to the SGLT2s, like the cardiovascular safety studies. I put in the summary of LEADER, REWIND, SUSTAIN, and they kind of all show the same thing, that if you put someone on a GLP-1 receptor agonist, the level of the protein damage markers, the proteinuria, will decrease in the urine. And we know reduction in proteinuria is associated with long-term clinical benefit. And the rate of loss of kidney function, the worsening of the GFR, is also going to go down. Now, granted, for some of these agents, there was a lot of noise in the data, but now we actually have a really big clinical outcome study called FLOW. That's the study of the semaglutide, in which this drug was specifically tested for its ability to delay the progression of chronic kidney disease. So FLOW used the injectable form of the semaglutide. It included people with loss of GFR, with reduced GFR, on average was 45, and they randomized them to placebo injections or semaglutide injections. They were targeting a dose of about 1 milligram subcutaneous per week. So if you're thinking about what's the dose that they were targeting in this trial, it's about 1 milligram sub-Q. And again, the study was very positive. They found that the rate of major kidney disease events, needs for dialysis, loss of more than 50% of kidney function, and death from cardiovascular disease was reduced by about 24%. The risk of death from any cause was reduced by 20%, and there was no real increase in the adverse events. So this is the trial that will most likely give semaglutide the approval to be used as an anti-chronic kidney disease medication. Again, some of the outcomes, just to show that it wasn't just like lumping three heterogeneous things together that gave them the signal. No, they actually saw a consistent decrease in all the components of the outcome, in the need for dialysis, in the doubling of GFR, doubling of creatinine, which is nearly halving of the GFR, and cardiovascular events. So they reduced every single one of them in isolation and as a totality. Some additional benefits that were noted in this study is that the weight went down by about 4 kilograms, A1C declined by about 0.8, and about 44% of patients experienced reduction in major adverse limb events, things like revascularizations, amputations, which was an interesting thing to note. And there was no reduction, no increase in hypoglycemia. GI side effects were the most common that led to discontinuation, and there were a slight increase in eye disorders, including cataracts, that were reported. They didn't see any of the retinopathy or the retinal disorders that people are freaking about, but some eye symptoms were reported at a high rate. Now, the last pillar of modern therapy is the mineralocorticoid receptor antagonist medications, in particular finerenone, the non-steroidal MRA that was specifically tested in diabetic kidney disease. Finerenone was tested in 2 large trials, one of which focused on people with severe CKD. It was called Fidelio, and another one that focused on people with less severe CKD but higher cardiovascular disease burden, called Figaro. The 2 studies you can see on the graph here, they kind of looked at both early and advanced CKD and high and low kidney damage markers. Again, another boring study. The medication worked after like 2 decades of failing one therapy after the other. Nephrology started like hitting every single one of those trials. So finerenone did lead to improvement in kidney disease, reduction in cardiovascular events, reduction in heart failure, reduction in death from any cause. In fact, they got 5 indications based on these 2 studies from the beginning. There was a higher incidence of hyperkalemia, which is to be expected. The medication works by blocking aldosterone. Aldosterone is involved in telling the kidney to get rid of potassium. So you may see slightly higher incidence of hyperkalemia, but the benefit was undisputable. Similar to the other drugs, this medication has an acute effect on GFR. It partially works, or we think it works, by slowing down the kidneys working overtime, and after a while you don't lose kidney function as much, which is what the blue and the red graphs show. And there was really very minimal effect on the blood pressure, so we don't think this is a blood pressure event. As I said, hyperkalemia can be an occurrence with these drugs, so people need to learn how to manage this. We know that in patients with advanced kidney disease, you can have hyperkalemia with or without therapies. It's just the kidneys who are tasked with getting rid of the potassium. Sometimes they don't get rid of the potassium. But if you manage the hyperkalemia, you can allow these therapies and the ACE inhibitors to be continued without any issues. So how do we manage them? We manage it by measuring the potassium so that we become aware of the problem. If there is an elevation, we can reduce the dose. We can convince the kidney to get rid of more potassium. So sometimes you will see us start the SGLT2 inhibitors, which allow a reduction in the serum potassium level with the MRAs or before the MRAs. And you can use a potassium binder. There are medications like patiromer or the zirconium. The trade names, and they're all trade branded, like Lokelma and Veltassa, are very easy to use, and they're very effective in preventing hyperkalemia. So there is a protocol on the studies that I can circulate offline that kind of gives you the various steps you can do, and you really shouldn't run into like severe issues with hyperkalemia. You will run into issues that you need to do interventions, but you're not going to kill anybody by through a hyperkalemic event. Based on all these 4 trials, there is a change in the paradigm of how we treat this disease. The change in the paradigm is based on this study, which basically tried to anticipate what may happen on someone who's treated with all these 4 agents: ACE inhibitors, sodium glucose transporter 2 inhibitors, flozin, that is, GLP-1 and finerenone. And they estimate that if we're able to get someone on all three three therapies and an ACE inhibitor, then we can reduce the risk of progression of kidney disease by about 60%. We can reduce all-cause mortality by about 30%. We can make hospitalizations for heart failure a thing of the past. So this is why you're seeing all the guidelines from both nephrology and endocrinology and cardiovascular medicine kind of converge to the same thing, that this disease requires the use of all four pillars of therapy. And effectively, we are translating the congestive heart failure model in this space. Again, some data, I don't want to spend a lot of time on them because you actually don't have really big trials, only secondary analysis of the existing trials that show that if you can get that the SGLT2s do not lose their benefit if you use them with a GLP-1. This is based on the SMART-C, which is a collaborative analysis of the patient-level data from the big SGLT2 trials. It kind of shows that you don't lose a benefit by using both therapies. In fact, some may argue that these data show that you are attaining an additive benefit. The combination of MRAs and SGLT2s has been looked into two different ways. One of them is the examination of eplerenone, the use of eplerenone or spironolactone in DAPA-CKD. The other one is the use of SGLT2s in the finerenone trials, and they kind of show that if you're on both therapies, you didn't lose the benefit of the individual components. There was some uncertainty whether you got additional benefit, but there was reassurance that you didn't have more side effects and you didn't lose benefit of any therapy. So where are we in 2025? So how we approach our patients. And this is where we really need to be thinking of how urgently we treat this disease. In the old ways, we could get our patients, give ourselves like 3 months to get them on an ACE inhibitor, an ARB, another 3 months to titrate the dose, then play a little bit with the SGLT2s. Then at the end of the year, maybe give them a non-steroidal MRA. And, a year after that, like put them on a GLP-1. That's the approach that we should not really be using in our studies. People do die while we're trying to figure out dose. So what I try to do in my practice is what's called the rapid sequence approach, in which I start at the same time an ACE inhibitor. Well, most of the patients come to me on an ACE inhibitor, but let's assume that they didn't. If they hadn't, I would do an ACE inhibitor and an SGLT2 together. Then very quickly put the non-steroidal MRA. At the same time, talk to the PCP or endocrinologist about doing the GLP-1. And within give myself 3 months to get them on all four and then do the titrations after the 3 months. As a sort of a compromise, one can do an accelerated approach, which, does the first two therapies, ACE inhibitor and SGLT2, give yourself 3 months to get them on these two, then another 3 months to get them on the other two, and then 4 months to do the titrations. You can do all of them without seeing the patients in the clinic. If you have like a program where with potentially pharmacist or case or, a nursing manager or nursing coordinator in the clinic, you can fire these drugs very quickly, check the kidney function, which is required after 2 weeks of an ACE inhibitor and at about 3 or 4 weeks with a GLP-1 and an SGLT2 or an MRA, and then use assessments of kidney function and proteinuria to encourage the patient that, things are working, and then continue doubling the dose until you get to the maximum tolerated dose for the ACE inhibitors and finerenone. SGLT2s are great drugs. They only have one-step therapy. It's what I call the rule of 10 milligrams of empagliflozin or empagliflozin should get you there. So some practice points, I really spoke about them. I really tried to maximize the ACE inhibitors or the ARB. I do implement potassium binding resins to allow me to maximize those therapies. Um, and I really try not to bother the patient with too many frequent visits. I tell them, do the lab, someone will call you, and then we do the dose optimizations, like through portals, messages, and stuff like that. Now, the elderly patients, this is actually a meta-analysis that we did with like my group about exactly a year ago, where we took the data from all the previous studies and we asked the question, do the drugs work differently in people with or without like advanced age? The answer was no. We actually, like, if you do the patient level meta-analysis, well, it wasn't patient level, it was group level meta-analysis. The drugs work the same irrespective of your age. And there was another paper that was published at the beginning of, actually mid 2024, where some of the investigators who were involved in these studies went into the data and they tried to come up with a frailty index of who's likely to get into trouble. And by trouble, meaning needing to be hospitalized or having changes in kidney function. And they found that this frailty, which was statistical, it was like your propensity or your risk susceptibility correlated very well with age. But the absolute benefits of therapy were actually higher in the frail people, meaning that our elderly patients being at higher risk for these adverse events benefit in absolute terms more than the younger individuals. That does not give us license to discriminate either way. It just like builds on the clinical trial data that showed that the drugs work equally well. With that, I will sort of like, I don't think we have time to speak about the transplant patients. Unfortunately, not a lot of data there, but the little data that exists, some of which have been released by our group in like meetings at the ASN, suggest that those therapies, especially the SGLT2s, are kind of safe. And if you get over your irrational fear of urinary tract infections, you can try them. And if the patient does not have a UTI, you can continue them without like thinking that the individuals will end up losing their kidney as a result of the medication. So thank you for your attention. It was rapid fire of a lot of data, more than 15 years in like 20 minutes. But I think the take home point is really, really simple, is that we need to be taking into account the cardiorenal risk when we prescribe therapies. We need to be using these agents aggressively and early, being very cognizant that some of the patients may not be able to get them because the insurances and the co-pays may be prohibitive. But one thing is really clear is like, you don't need to worry about, should I use one of those therapies when someone's GFR is low? This is irrelevant. Just start those therapies, assuming the GFR is over 20, because that's when the trials, the cut of the trials had to initiate the therapies. Otherwise, they continue them all the way to dialysis. And your patients will derive benefit for their heart, their kidney, their heart failure, and they will live longer lives. Thank you.
Thank you, Christos, for that excellent presentation. Lots of good comments in the chat. As we get our case report up, and we'll ask Sarah Thompson to start, I'll just ask you the question I've been asking a lot of people. Especially in lower health literacy, how do you support them outside of glycemic control, those risks? Because our highest risk patients often don't want multiple medications.
Yeah, so that's a great question. I think one needs to learn or understand their patient population better so that they can do their branding. So We have not had issues with compliance with the SGLT2 agents. We kind of explain to patients that, they may start being more, they may feel a little bit better as they're decongested from heart failure, and it's one pill once a day. So, like, one of the benefits is that these therapies are extremely user friendly. It's like one pill a day or one injection per week. The GLP-1s actually sell themselves nowadays because of the weight loss. Like, and our experience has been that unless someone developed, for example, the GI side effect or frequent UTIs, and when people talk about the SGLT2 inhibitors and UTIs, they need to remember that a yeast infection is not a UTI. The risk of a bladder UTI is increased by maybe 9%, like relative increase. So it's really very small risk on average. So when we talk to people, the direct to consumer advertising, which actually works quite well, like some of the patients have seen the ads. My daughter and her friends at 8th grade are singing the ads, like for for Guardians, which was I was surprised that when I picked like 14-year-old girls and they were singing Guardians in the car. I said, well, okay, what's this? They sell themselves. I think the benefits sell themselves. The risk for hypoglycemia is not elevated. That's what scares people. And you have the collateral benefits, especially with the GLP-1s, which is the weight loss that sells themselves. Like battling the co-pays is a very different story, though. That has been our nemesis here.
Yep. And so it seems like the summary is just offer it to patients and explain it to them. So
Yes.
on that note, I will ask Sarah to go ahead and start our case.
Sure. Thanks, everyone. My name's Sarah Thomas. I'm a pharmacist at a community health center. So this is my case of a 53-year-old male, Spanish speaking, that was referred to clinical pharmacy for support with diabetes medications. He has a long history of poor med adherence. When he was referred to me, he was prescribed basal insulin along with an oral regimen, but he was using his basal insulin really infrequently due to kind of inconsistent family support at home because he's got vision impairment and wasn't able to self-administer his insulin. So I'm looking for some guidance today on kind of ways to support someone with vision impairment that might need injectable therapy. And more importantly, I guess, or not more importantly, but also of note, he's actually been doing pretty well on oral therapy alone as we've been working with him to improve med adherence. So I'm also curious about using a GLP-1 in a patient with a severe retinopathy and what kind of our considerations are there. So here's his history. He does have CKD, hypertension. His blood pressures have been really labile in clinic. So that's another thing I've been helping kind of support with monitoring. He had 2 eye surgeries canceled because he'd go in and his blood pressure was over 200 systolic. And then he'd come back to clinic and it was normal. At home, he was having lows. So he's just been needing a lot of frequent touches for with his care team. Current meds are listed here. He's currently on for diabetes management a combo tablet, which he's able to take once daily in the morning. He's on a couple different blood pressure medications. The furosemide was started recently by his nephrologist. Glargine's listed there. It had been prescribed for him. He's not taking it consistently. I don't have him using it at all currently because he was only getting doses maybe once a week from his son when his son was at home and available to administer it. Family history is pretty limited. He's from Mexico originally. He did note that his brother was on dialysis for a short period of time before he passed away. Most recent A1C was drawn in December at 8.3. I think I put a trend down a little bit lower. Earlier in 2024, it was at 11.7. Then he was using some insulin, sometimes bounced around 8s, 9s, but has not been well controlled consistently. We aren't able to download CGM data at our facility, but I kind of was able to summarize it here. And I met with him yesterday. He's been consistently maintaining about 135 average glucose on his CGM on oral agents. And he was about 93% at goal with more consistent use. He had restarted monitoring consistently. A lot of kind of barriers to care. He's got pretty limited health literacy, language barriers, transportation barriers. Our clinic's supporting him with a lot of those things at his specialty appointments as well. And he has met with our dietitian in clinic. He's trying to work in this area as well, but because of his vision impairment, he really only eats healthy meals when his son is home cooking for him. Other than that, it's what's available and easy for him to make and grab on his own.
Great case. And just because of time, we're going to go ahead and start our case discussion. So go ahead, Laura, take it away.
So we're just going to review, just kind of summarize and obviously get to the recommendations here. So great case presentation, but recapping, we've got a 53-year-old male with type 2 diabetes, retinopathy, chronic kidney disease, hypertension, glaucoma, cataract, and he has a history of alcohol abuse over a year ago. His vitals are there, and as Sarah had mentioned, blood pressure has been variable, and there have been some issues with adherence to medications because of the vision impairment, and his family support. At least when his son is around, that does help him more so with his diet and nutrition. He has been improving his adherence to at least oral meds, but he hasn't been taking the basal insulin specifically. And just kind of showing you again the labs, and Sarah has here the trend in A1C, so it looks like it's been improving. And of course, his medication list, which we just went over. And the CGM data just highlighting that again. And it sounds like he's doing much better on the most recent download on January 7th. So a few clarifying questions that we had as a group, and Nicole in particular, was, can this person see the CGM, or does someone have to read it to him? And it sounds like he can use a magnifying device, and he'll listen for the audible alerts when needed. And we also asked how long has the patient had protein in the urine for, and probably since April 20 of 2022, but there was no prior lapse, as Sarah mentioned. Does the person have proliferative or non-proliferative retinopathy, and any therapy like laser or injections needed for the eyes? So Sarah had let us know that the patient does have proliferative diabetic retinopathy and is seeing a specialist, and has some treatment in both eyes, a procedure. In particular, they repaired a detached retina with a vitrectomy. He's had laser and gas. And we also asked about, nutrition and weight stability, and his weight has been overall stable. It looks like since 2018, and it looks like he's made great progress, our patient, in terms of reducing sugar beverages and soda, and is now drinking only at least down to one per week. So recapping again our individual patient characteristics. I know this is a lot of information, but just kind of run through this quickly. 52-year-old Spanish-speaking male. He does have insurance with the Oregon Health Plan. The BMI from the vitals that we have showed a BMI of 24. He does have limited health literacy, limited social support, at least when his son is traveling or not home, unemployed. He does have this vision impairment, no smoking, and he has quit alcohol about a year ago. And his current A1C, at least in December, was 8.3. He had a microalbumin creatinine ratio of 290 milligrams per gram. His EGFR in January was 79. Blood pressure, quite variable. As Sarah mentioned, he's been on lisinopril. He has hyperlipidemia. He's on a lower dose of atorvastatin. He does have barriers to using insulin because of his impairment, so he's not been taking that, but it sounds like he's been doing really well with his triple therapy, the empagliflozin, linagliptin, and metformin. And I know you guys learned about this Prevent Online calculator in previous discussions. So his cardiovascular risk, in particular, over 10 years was 17.2%, which was intermediate risk. So our first question that we always ask, does this person produce insulin? Is this type 1 or type 2? Are they insulopenic or insulin resistant? And from looking at his trend, considering the patient hasn't been on insulin, it sounds like we're probably are dealing with a type 2 diabetes. Although, one, I guess, thing to note is if we do see worsening or there is an improvement, we may want to consider doing the C-peptide antibodies to assess for a type 1 situation. And what is his A1C goal? So his A1C goal, considering his risk panel, we're probably going to be wanting it to be, less than 7, less than 6.5 in particular for this patient, 6.5 to 7%. And we want obviously to get this goal without the patient having low blood sugars. Third question, so does the CGM data match his A1C? So, well, not quite, but potentially there's a bit of a delay in us seeing the change, but also as we've learned before in other presentations, we may want to rule out other causes of possibly inaccurate hemoglobin A1C, like B12 deficiency, for example. So the questions that we want to work through in the time that we have is, in the setting of diabetic retinopathy, with a recent repair of a detached retina, would once weekly GLP agonists be an option, given his issues with, adherence to insulin? And what should we use, considering he does have this retinopathy? But also in the setting of vision impairment, are there any tips for insulin use? But also, I think we should just, discuss today with his vision impairment, nutrition and exercise, like lifestyle suggestions as well. So I'm going to pass this off to my colleague Nicole to discuss some strategies for treating diabetes with low vision.
Thank you, Laura. So this is the ADA website, and this was just some of their suggestions, and primarily just using a magnifying glass, which is already what this patient does. And so, but this is a resource that you could refer your patients to. Next slide. The other thing we want to talk about is just being aware of our different devices and how they work, right? So something as simple as having a drum rather than one Lancet device where you have to load things individually might be helpful for a patient if they're using a meter. There are talking meters. The Prodigy meter does have a voice activation. And then, one great forward movement for continuous glucose monitoring is that our Dexcom, our G6 and G7 can be coupled with Siri, and so you can actually hear and they can say the blood sugar. So that's been great for people who truly cannot see their CGM device with a magnifying glasses. As well, I learned that with our Dexcom device, you can actually change the tone. So you can individualize each tone for like urgent, low, whatever level you set for high, so they can be also alarm indicated. Unfortunately, this is not yet available for our Libra system, which are very often commonly used. But again, they would at least hear an alert. It just won't be specialized, so might be hard to tell if it was low or high if they were truly blind and couldn't use a magnifying glasses. But those are just some thoughts. Next slide, please. And then the other thing to remember is that with insulin, we often teach via clicks. And I did touch base with my CDE, and she said she felt like all the pens out there, you can hear a click with each number. And so you can tell them to just do 1 to 2 clicks for priming, and then to push the button, and then to click then to their dose of insulin. Again, that can be intimidating. But using a magnifying glass is also a possibility unless they truly have blindness. And then next slide. The other thing to think about is, especially because the sun is intermittently available, you could use something if you needed multi-dose injections. A Vigo patch insulin, it delivers a set amount of hourly insulin to create a basal rate, and then the clicks are each click that they can do is 2 units of insulin. So this could be used in someone who is visually impaired as long as they had someone to set up the device every 24 hours for them. Next slide. And then next slide. And also there is C-Core, which doesn't have an hourly insulin device, but just could be used for prandial insulin. Again, every click, and it's a very distinctive click, is 2 units. And so this would be another option for someone with visual impairity. Next slide, please. I'm going to pass this over to Dr. Wright to talk about GLP-1s and retinopathy.
Yes, thank you. So this is the results of a meta-analysis looking at GLP-1 receptor agonist and diabetic retinopathy. One thing that is important to notice is that these trials, they were not designed to look at diabetic retinopathy. These are trials that look at cardiovascular benefits, and in this meta-analysis, there were also other randomized controlled trials that look at just the efficacy of the GLP-1s. And most, as you can see, right, like most of the GLP-1s don't appear to have an effect or negative effect on retinopathy. It was mainly with Sustain, which is semaglutide or Ozempic, when we started to see, this increased retinopathy. And then that was also observed in Pioneer, which is oral semaglutide. So, like again, is many of the other trials are considered safe. Actually, liraglutide, like LEADER, was actually kind of like show some benefits in diabetic retinopathy, not statistically significant. Okay, so, and then let's see the next slide. Can I? Yeah, okay. Yes. Now looking at tirzepatide or Mounjaro, since this medication is the newest of the GLP-1 GIP agonist, these studies, they are not really that long. Many of these studies haven't actually even looked at diabetic retinopathy. So we, so far it's considered safe. There is really not a signal, but again, let's take that as a grain of salt because we don't really have like long-term studies. The good news is that next slide. The good news is that there is currently a trial with semaglutide that is specifically looking at diabetic retinopathy. So then we will, hopefully have results soon. The other thing that I wanted to mention is because this patient, right, like is on a DPP-4 inhibitor. So I just wanted to mention that it is not a good idea to have GLP-1 and a DPP-4 together. The reasons for that is, one, the mechanism of action is kind of like redundant. And I won't go through the mechanism of action right now because of time. So, and also, there is no added clinical benefit, possibly because, like again, the mechanism of action is redundant. The GLP-1 receptor agonists are have more efficacy and they have cardiovascular benefits. Hypothetically, also, like again, this is hypothetical. By combining these medications, they might have an additive effect on side effects, including pancreatitis. The mechanism is not clear, and this is just hypothetical. Yeah, so then in this case, I think I would choose a GLP-1 receptor agonist, but perhaps not semaglutide. I would choose a different one, perhaps like a weekly GLP-1, but not semaglutide because of the data that we have. And we have other options.
Yeah, and Nicole, as our other endocrinologist on the panel, any other comments on the retinopathy?
I think what's great is we'll know in early 2027 or late 2026 the results of the focus study, which will really give us our answers. But I think we have to highlight that in general, some of the retinal disease that we're seeing is because of the rapid lowering of blood glucose, which we've talked about before. So we just want to make sure in those that start off at very high A1Cs that we do a more moderate A1C lowering. And that could be the mechanism, not from necessarily a mechanism from the drug itself. And then I was just actually looking at a study that was a large database review, and those that already have proliferative nephropathy, proliferative retinopathy, there was 86 patients, and they actually looked then if they required more injections or had progression of their disease or more laser treatments. And actually, they found no difference in need for further therapy in these patients. So all this data is very reassuring for our GLP-1 receptor agonists. But we're going to get more definitive answers once we have our prospective trial that it will be completing in 2027. So thank you.
Great. So I want to just touch a little bit on non-pharmacologic treatment. And in particular, patients with diabetes, we do want to assess for other, comorbid conditions like overweight, obesity, and of course, we want to optimize lifestyle. So going back to a slide that I shared a few weeks ago, so BMI is one of the ways that we can assess this. And for this patient, recall his body mass index was at 24, so he is in a normal weight. But I just wanted to highlight this patient is a Mexican American, but Asian American. The BMI cutoffs are going to be a little bit different, so just be aware of that. And just before I pass this off to our dietitian expert, I just wanted to touch on one lifestyle modification. In addition to nutrition, we have exercise, and exercise, as we talked about before, it's very critical to prevent weight gain. It does help improve insulin sensitivity. Patients should start slow and gradually work up. And Nicole actually found a really great resource here where it's an app that actually describes and goes through the different workouts for patients. So a nice resource that she's included. And then this is a picture that I took actually from a colleague of mine, obesity specialist, David Propst, who's a physician assistant. But he kind of meshed together a few images from other studies. But this was a meta-analysis which highlighted the importance, just published, but highlighted the importance of resistance training on cardiometabolic health in patients with type 2 diabetes. And out of 1,180 patients, average age 63 years old with a BMI of 29, there was a huge number of improvements associated with resistance training, including reducing fasting glucose, A1C, improving triglycerides, and increasing HDL. And then I'm going to just pass off to our expert dietitian to talk about some nutritional considerations.
Okay. In particular, this individual with vision impairment, working with him, I think it's always really important to ask open-ended questions. And I apologize if you've heard me say this before in previous echoes, but when we ask open-ended questions, we find out what the patient knows. I always say, I don't know what the patient knows until I ask them. And it takes about 7 seconds to formulate an answer. So if you're working with an interpreter, it might even take longer, but it's so important to take that moment to really ascertain what the patient knows, because we know the primary determinant of the postprandial excursion is carbohydrate. And so asking the patient to identify sources of carbohydrate. And then I think the really other common thing that, that we need to do in follow-up then is to ask them what they eat though, right? They might be able to rattle off a whole bunch of carbohydrate sources, but what is that patient actually eating? I think for a visually impaired patient, that concept or the idea of that China picnic plate that has the wells in it, a quarter of that plate is a fist-sized portion, which, for many of our patients with diabetes is a healthful portion to start with for those starchy carbs or the starchy vegetables. Another strategy that I often use with visually impaired folks is ask them to get some plastic cup measures. You can do that at the dollar store. You can do it at a Fred Meyer, a large grocery store, at Target. Doesn't have to be a designer. But they can actually, if they have food that is self-prepped, they have rice or beans or pasta, they can actually use that cup measure as a serving tool. So if they're not using a plate that is portioned, they can actually then portion out their portions. Non-starchy vegetables are not as high in carbohydrates, so you might say, if they're eating those starchy things, it's a 1 cup portion. If they're eating non-starchy vegetables, they can have 2 cups of it. I do encourage people, fruit is good for you. It tastes sweet. You can eat it every day, but I usually say a serving is something that fits in a cupped hand. And so that is a frame of reference that they can take with them. Those plastic cup measures, if somebody is at the home that can measure up some of their glasses, many glasses have gotten a lot bigger over the years, and your patient might tell you that they're drinking 1 cup of juice or 1 cup of Gatorade, but that cup, it might have 24 ounces in it. So using those cup measure to kind of quantify some of the beverage containers they have at home. And next slide. In terms of protein, since this person does have CKD, in terms of the ADA and the KDIGO guidelines, they kind of align on this 0.8 grams per kilogram body weight, ideal body weight for somebody not on dialysis. So if we do the math for this patient, that's about 46 grams of protein per day. And if we are encouraging people to eat plant-based portions of protein, we just need to check their renal status, because these beans and lentils can be very high in potassium and phosphorus too. So just to keep that in the back of your mind in terms of the level of kidney function your patient has. But I think it's helpful for a patient to actually help them visualize what a serving is. If you tell your patients, 40 to 50 grams of protein a day, that won't mean anything to most people. But if you have them look at their palm or visualize a deck of cards, that's a 3-ounce portion. That's maybe a third of their, or in this case, half of their protein, per day. A hand-sized portion is more like 5 or 6 ounces. So in the United States, most people have too much protein. I know with maybe you've had an earlier obesity lecture, and we are seeing patients using these for weight loss and obesity management, getting higher doses of protein, 1.2 to 1.5 kilograms per for ideal body weight. This patient, I don't know, you'll have to find out if they're a milk drinker as well. And then just reinforcing other heart healthy, hypertension healthy guidelines. I noticed one of the things that really jumped out for me for this patient was the use of instant soups on the dietary history. And that might be a good swap out if somebody is purchasing foods for them. There are lower sodium canned goods that patients can buy. But just to also coach and remind patients in your practice, if we are asking them to cut down on salt, that the taste buds get dulled by sodium. And so it's going to take several weeks for that patient to kind of get over the blandness, but just tell them to hang in there. And now I'll stop talking.
Allison, as always, great teaching points. I love the idea of the deck of the cards, and then, just the practicality. This is someone who has blood pressure issues and renal disease, so easy ways of finding lower sodium foods. Thank you so much. So we're now just going to talk about medication management. And one of the questions was, does this person even need insulin? And it sounds like the primary care provider sort of already answered that as a no, right? Because by the GMI, by the average glucose, by the CGM, this patient is looking optimized. That would be an estimated A1C or GMI of less than 7% currently. If in the future this person worsened, you could consider such things as pioglitazone, a low dose of glimepiride. Those do not have any cardiovascular renal benefits. So this is where the education of the patient would come in. But doing a dose of a GLP-1 receptor agonist like dulaglutide, 0.75 milligrams weekly that could be injected by the sun might be a great option, and decrease barriers to care. And if additional medications are needed to get, and I would probably consider starting an additional medication if the GMI was greater than 7% in this patient. What I wanted to highlight and what is great about the Oregon Medicaid formulary was that they have triple diabetes therapy on their formulary. I did check for some of our Washington area Medicaids, and what you can see is you can use metformin and SGLT2 inhibitors. I both saw canagliflozin and dapagliflozin combined with extended release metformin. So at least you could have dual therapy, and then you could consider adding a weekly GLP-1, but we did not have that. And then thinking about his barriers and his blood pressure being a little label, I did see that we do have amlodipine and an ACE inhibitor on formulary. So you could do a combination of that pill if you needed additional blood pressure control. Additionally, it looked like the combination blood pressures that were mostly formulary were like diuretics like hydrochlorothiazide with a beta blocker like metoprolol. So just thinking about that, it took me a long time to scroll through and find them, but that might be the best time. That might be something that's worth your time in order to reduce the pill burden in this particular patient. And then, what Laura had highlighted earlier is that we did calculate his cardiovascular risk, and he is at over 17% risk. And so, it is someone that I would think about, do we need not just diabetes management? We need outside of glycemic control, both to reduce his cardiovascular risk and his renal risk. And so, we're going to target an A1C less than 7. This is where I would say I would maybe even target a blood pressure goal with our newer guidelines of less than 120/70, given his renal disease, and an LDL of less than 70 as his primary prevention. And so, we may not need to change his therapy, but remember that linagliptin is cardiovascular and renal neutral. And so if we wanted to choose the weekly GLP-1 receptor agonist, and we were worried a little bit that we didn't really want him to lose any more weight, that's why we'd sort of been talking a little bit more about deglutide. And I thought the Award 5 highlighted this well. It looks at 1.5 milligrams and 0.75 milligrams deglutide as compared to a DTP4 inhibitor, sitagliptin. And you can see how weak of agent sitagliptin is, and that you get greater than 1% A1C lowering at the moderate dose of deglutide, 1.5 milligrams, with only on average, about a 6-pound weight loss, which would probably be acceptable in this particular patient, especially if he was working on that resistance training that Laura was talking about. So just something to consider. This is, I think, another point in our elderly population. So a lot of times we want them to not suppress their appetite too much to maintain their weight, but we want ongoing glycemic benefits and high efficacy, and also renal and cardiovascular benefits. So thinking about the agents on the other side, those that do not create as much weight loss, are as important to highlight as well in certain populations. So this was just my summary, that we want to continue his current therapies, but over time we might consider a low dose of GLP-1 receptor agonist and replacing the linagliptin. And then we want to we want to optimize the rest of his cardiovascular risk by increasing his atorvastatin to 40, so we get him to less than 70. Considering a combination drug and a second agent maybe for his blood pressure, although they've been very variable. And, we just want to encourage healthy lifestyle that he can do like small changes and just applaud him already for decreasing his sugared beverages. And I'm going to ask our expert speaker, um, it sounds like I already have the answer, but how hard would you push for a GLP-1, sodium glucose cotransporter inhibitor, and then finally finerenone in a patient like this?
Yeah, very good question. I think with someone like this individual, we cannot like forget about glycemic control. All these therapies, and I should have mentioned this in the talk, do nothing about the eye disease. So, but we know from the literature from the 90s that glycemia control is what prevents the retinopathy. So for a person like this, the probably how I would layer the therapies is try to get them on the GLP-1 therapy that's actually very user friendly once a week for the management of his diabetes. An SGLT2 inhibitor, which is a once a day drug with a GFR of 79, will also contribute glucose lowering effects. But the downside, again, it's like a daily pill that he has to take versus an injection once a week that maybe his son can help him about this. And after those therapies are done, and assuming that there is, that there needs additional therapies, such as if the protein in the urine is over 30 milligram, then I would layer the finerenone. So that's how I would approach the therapy on him. The antihypertensive, this is actually the group of patients where we would go with the combos benazepril versus amlodipine, or amlodipine plus the ARB. And if you need a third agent, there's also a combination product that has hydrochlorothiazide. So that's how we would really try to approach it, like simplify the regimen so that it's only like a few pills or one injection per week.
Thank you, Christos, for this summary. And I'll just say this ends session 10 of the Cardiometabolic Echo.